All right, in a few seconds, I'll go ahead and get started. All right, hello everyone, and thanks for joining our webinar, Leveraging IMO Core for Improved HCC Functionality. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. First off, this is being recorded and will be available to you after the presentation. Throughout the session, all attendees will be in listen-only mode. During the presentation, we will ask some poll questions to kind of keep you all engaged. And at the end of the webinar, we'll have a Q&A session. So if you had any questions coming into the webinar or during, we will address them at the end of the webinar. With that said, we have three presenters from IMO. June Bronert, she's our VP of Global Clinical Services, Sheena Koch, our Senior Product Manager, and Blake Carson, Director of Client Services. So without further ado, I'm going to pass it on over to June.
Great. Thank you, Jordan, and welcome, everyone. Today, you can see here the agenda of what topics that we are going to be covering. We're going to start with an overview of IMO, turn our attention to the basics of HCC, while also reviewing product features of IMO Core, along with the technical how-to for IMO Core, with the focus being on how IMO Core enables HCC features and functionalities. So let's get started. At our heart, IMO is a data enablement company founded on our clinical interface terminologies to enable providers to say what they want to say without the constraints of standard coding systems, while ensuring maps to the necessary codes and code systems. We were founded nearly 30 years ago, and in that time, we've become the language of healthcare, particularly when it comes to documenting the problems and the diagnoses. So, IMO is a data enablement company. What does that mean? At a very high level, our terminology is the gold standard for a variety of use cases, such as structured documentation at the point of care, as well as solutions for back-end aggregate data standardization, natural language processing, and value set management. It is the foundation of everything we do. So let's take a closer look at our terminology's depth and breadth on the next slide. Here you can see our clinical interface terminology offers a wide range of healthcare concepts, which are not confined to the constructs of a standard code system. This supports representation of nuanced disease states, which are not present in an industry standard code system. This slide shows an example of our content ranging from genetic defect all the way to specific chromosomal alterations of group C and X. And on the next slide, we'll look closer at our content, including IMO's approach to the industry standard code systems. Being a novel disease, when COVID first emerged, there was no specific COVID code for it. But obviously, there was a need to be able to document patients with COVID in a structured manner that would support reporting and surveillance. IMO created concepts for COVID as shown on the left-hand side of the screen. Each term had a unique identifier mapped according to the latest coding guidance. And as the disease state evolved, we continued to create concepts such as COVID-related complications, like pneumonia due to COVID, while the industry standard coding systems were evolving. IMO monitored those changes, updated our mappings according to the changes, and the industry coding guidance was rapidly evolving during this time. So our terms remained stable while the mappings would change, allowing for minimal disruption to our customers' workflows. And now it is time for our first polling question. How often are your end users asking about HCCs and their functionality? So Jordan, yep, please launch the poll.
Yeah, so is it never, infrequently, frequently, or every day? I'll give it a few seconds while people respond, and then I will end it. All right, so it looks like typically frequently is kind of how often we think about it.
Thank you, Jordan. It's interesting to see your end users' interest in this topic. So let's turn our attention to the fundamentals of risk adjustment in HCCs. And we will first start by defining what is risk adjustment. In general, risk adjustment is a prospective method used to calculate healthcare provider payment based upon individual health needs. The underlying theory is the greater the person's health needs are, the higher a provider should be reimbursed. Risk adjustment is prospective in that it uses an individual's health state in a year to predict annual expected costs in the following year. Elements such as diagnostic data and patients' demographics are used in the prediction via a calculated risk score. And as you can see on the slide, risk score represents the predictive cost an individual as compared to an average Medicare patient will need. Risk adjustment is used in various Medicare programs, as we will see on the next slide. Here you can see different models that utilize risk adjustment methodologies such as the HHS, HCC, PACE, and the ESRD. We are going to focus on CMS's HCC model for our discussion, so let's take a closer look. CMS's hierarchical condition categories aren't a new concept, but as more and more organizations shift to value-based care, there's been a renewed interest in the model. And it does make sense. Having the solid foundation of HCCs supports many of the healthcare items such as reimbursement, along with having the continuity of care and the quality of care, while reducing the risk for an increased burden around the management of longitudinal health outcomes. Here on this slide, the 5 characteristics shown are all key attributes to risk adjustment. We already discussed some of these attributes, such as prospective in nature and the demographics. We're now going to look a little closer at the other 3, as the other 3 are related to the patient's diagnostic conditions and the documentation of those conditions. We'll look a bit closer at how diagnostic conditions are part of the model. The diagnostic conditions are used to establish condition categories. These categories have similar clinical characteristics and cost implications. A hierarchy of the condition categories was established to ensure the most severe forms of a disease state is used in prediction and reimbursement. Here you can see a few examples of HCC categories. The model was created using ICD-9 CM codes until recently, as we will see on the next slide. Again, recently, CMS finalized an updated risk adjustment model based upon ICD-10 CM codes. This adjustment was known as a clinical reclassification and established the model version 28. On the slide, you will notice version 24. This was the model version prior to the clinical reclassification. CMS chose to phase in the implementation of version 28 over a 3-year time frame due to the significant change in nature. And the industry is managing 2 different versions, version 28 and version 24 of the CMS HCC model. The slide also shows the individual ICD-10 CM codes and how they are part of an HCC category. So we will summarize the key elements here to remember when it comes to CMS HCC models are that the risk adjustment model is prospective in nature and the data collection time. Clinical specificity is key to ensure the most severe form of a patient's condition is accurately documented to reflect their disease state. And the conditions must be evaluated and treated every year to impact a patient's yearly risk score, which ultimately leads to the provider's reimbursement. And this is where technology and providers may intersect to support managing these risk adjustment models. And now it is time for our second poll question. Which HCC models are most important for your organization to support your end users? And you can see the choices on the screen. So Jordan, will you please launch the poll?
Yep. So is it CMS version 24, CMS version 28, HHS for ACA, CDPS for Medicaid, end-stage renal disease, or PACE for elderly populations. Just going to give it a few seconds while everyone responds, and then I'll push it back to you, June. All right, so it looks like version 24, version 28, CDPS, and then PACE.
Yeah, it's great. And that's pretty common, again, as the industry is managing two versions that are, while there's some things that are unique, there's some things very different with those. So now we're going to turn it over to Sheena to talk around IMO Core overview.
Awesome. Thanks so much, June. So very excited to present to you all today some of the capabilities that we have here at IMO in-house that help drive our ability to help providers and provider systems do just that. And so here's sort of a view of how we have evolved our capabilities to be able to support substantiating the problem list and making sure that they are accurate and up to date. So if you look here, IMO Core really builds on that precise problem terminology to ensure that in addition to just clinical documentation, we have accurate and a full breadth of clinical content that enables problem list workflow, IMO Core capabilities that allow us to clean the problem list, organize the problem list, and support efficient routine problem list maintenance. Building on that, IMO Discovery capability is a sophisticated point-of-care problem list tool that really uncovers undocumented chronic conditions, like the ones June just mentioned, that really help give the provider a clearer understanding of the patient's story and drives more accurate outcomes from numerous use cases of structured data. Next slide. So why does this matter? Really, as we all know, there is a healthcare system data gap. And there are a couple different focus areas, one of them being interoperability. And so when we think about different data systems, there's oftentimes inconsistency between the data types and modes of transmission. So we think about things like APIs versus EDI and X12 transmission standards, HL7, flat files, you name it. But essentially, that lack of data field standardization across health systems leads to a ton of gaps with regards to interoperability. Then there's transparency. So we think about how health systems communicate with other entities like payers and other health systems and other physicians. And then we think a little bit about the data quality aspect. And so really important foundational aspect of this is making sure that appropriate and specific clinical documentation really starts at the point of care. And IMO's capabilities are sort of what help us drive that home. So let's talk a little bit about how IMO Core helps with the search and modification workflow for providers. So our proprietary ICD-10 modifier workflow offers a streamlined workflow to encourage the capture of the most specific ICD-10 code by presenting targeted questions to the provider so that accurate and fully specified coding can really be captured at the point of care. And so in the example that you'll see here, with a single click, CKD was further refined to stage 5, which is an HCC, and on dialysis, which is an even higher RAF score, and of course adds to that clinical context that's required to really sum up the full breadth of patient care. I'm going to hand it over to Blake to talk a little bit about what the search and modify workflow would look like on the back end.
Thanks, Gina. Yeah, so walking through what it would look like from the technical perspective of how to enable HCC indicators at the time of the search experience within your application, there are a few different options. We would likely recommend the third path here, but depending upon what your providers are used to seeing and what you as an organization have pulled your customers to understand what the value would be, there's a few different paths. Number one would be including an HCC v24 indicator and how to find that information within the search payload of our Portal Web Service API is to look at the HCC model cat attribute within the payload. And if that is a non-null value, then you can use that to display a v24 indicator. Similarly, for the v28, we're storing that information in the HCC model cat next attribute of our search payload. And that can be leveraged to display a v28 indicator to your end users. And again, for our recommended path, we would choose a blended v24 and v28 indicator where the HCC model cat or the HCC model cat next are not null values. So what we've shown here on this slide demonstrates from the IMO's point of view what we believe is a good indicator to surface to an end user for HCC information at the point of care, so that they understand that when they select this diagnosis or problem, that this is an HCC condition. And these UI elements may be anything of your choice, right? Depending upon your look and feel, UI, UX of your application, you can choose to implement this in a variety of different ways. And the IMO implementation team is happy to work with all of you to ensure that whatever you're deciding will make sense from not only IMO's perspective, but from our experience of doing this with many different partner applications on how to leverage this in the best fashion. One final thing to note is we do tend to see some implementations surface the actual HCC RAF value within the search experience. Now, this is an optional thing. However, due to the complexity of these models, especially with this being a blended model approach, this is not something that we tend to see very often. Because, right, there are 6 different community factors for the V24 model. There are 6 community factors for the V28 model, which are choosing the right one is dependent upon the patient demographics, which are right unique to each individual patient. So generally, we recommend a general approach of just displaying an HCC indicator, whether it's V24 or V28 or a blended indicator. But did just want to call out that within our HCC community factors and community factors next attributes within our payload, that tends to be the most common community RAF that's used, which is the non-dual aged value, which we feel is a somewhat safe approximation of what that RAF score would actually be from selecting that diagnosis. So you can accomplish a similar thing within the problem list sorry, I went too far. Apologies. Sorry, Sheena, it's actually back to you. I was jumping ahead too much.
That's okay, it's good stuff. So as Blake alluded to, there's a ton that we can also do to implement this into the problem list. And so what you guys are seeing here is an actual view of what that problem list simplification and reconciliation workflow would look like in a UI. And so because of the gaps that we know exist in clinical data and because of our expertise in terminology, we created IMO Core. And so that really is a suite of advanced terminologies and problem list tooling like you see here that can organize and contextualize and really curate the data on an active patient problem list. So essentially, IMO's problem list organizes the problem list into those intuitive categories that you guys see here. It identifies and removes duplicate, outdated, and related problems with ease. And it includes a rule engine to identify and remove common types of problem list clutter that can help reconcile outside data or suspects and offers clear identification of those problems that may be relevant to a specific risk model, such as CMS HCCs for Medicare Advantage, with color coding to indicate those that are unaddressed for the calendar year. And that's that discovery capability. So also really important to sort of call out that opportunity that this sort of tooling also gives for improving inbound problem reconciliation workflows. And I'll hand it back over to Blake to talk a little bit more about that.
Yeah, so thanks, Sheena. But by default, the categorize endpoint can be used for that left-hand side screen that Sheena was just sharing for the categorization of those problems themselves. You can also leverage this for ensuring that any existing problem list data and any outbound problem list data are matched up effectively to leverage those capabilities that Sheena was just highlighting. So on the right here on the slide is just a pretty straightforward API request for that categorize endpoint, which includes the provider specialty, which is an optional parameter to include within the response. So we'll return our default categorization view for anything that does not have a specialty included. But if you include a specialty, the relevant problems or the relevant specialty view will be pulled to the top of the result set in that problem list view. so that those providers can hone in on specifically what's important to them for that visit. And on the right, I'm also highlighting the ability to send in not only existing problem list records, but outside records as well. It doesn't necessarily need to be highlighted in this ID value that you see on the right-hand side, but it can be, you can, what we recommend is including some sort of identifier to tie back to the originating problem list record or the originating outside entry record, so that you can understand where this data is coming from and how to take action on it. So we recommend always including both the existing problem list entries as well as those outbound records. Additionally, we recommend including certain pieces of metadata within this request if it's known and available to you folks, such as if you're using the problem search on your side, you should be capturing that IMO lexical ID within your backend database system. And you can leverage that to send information to the categorize request, which will automatically identify that as an IMO term and return the appropriate information back. If you don't have an IMO ID included, we have 3 different possible ways to essentially normalize on the fly to an IMO term. And that can be through the problem's description itself. If you don't have that, you can send something like a SNOMED code, or if you don't have that, you can send something like an ICD code. And either 3 of those things can be used to normalize to an IMO term to ensure that that outbound record is now IMOified, if you will, and can then be in the future used for the remaining operations that I'll go through in a second here. So really quickly, first, we'll talk about how to generate those problem list indicators within the UI itself. So not only should you bucket each individual IMO term under the respective category that is being returned, which can help on the fly or from a provider's view, identify those things that are similar in nature, which we'll get to the cleanup operation in a bit here. But the categorize endpoint is slightly different than the search endpoint. Instead of a non-null value, we'll look for non-zero values for these HCC v24, v28, or blended indicators. So you can see in this payload that we've got HCC category code and HCC category code next, which are those model category values, which can be used to power the UI to display an indicator at the time of viewing the problem list. Now, using the clean endpoint, this similar operation can be done where you can include both existing problems on the problem list as well as data from outbound sources. And this is a really effective way to reconcile data from outside sources into your problem list to ensure that there's no duplicity within that problem list and ensure that it is clean so that the providers can actually make good use of it. So within the clean response, what you'll get back are 3 different objects. The lapsed objects, which are temporal problems that have lapsed or should no longer be on a problem list based on the problem entry date. For example, if you had a broken left leg from 1995, that's something that, broken bones tend to resolve fairly quickly in the grand scheme of things. So those should not or tend not to exist on a problem list, and we will flag that for cleanup as a lapsed item. The other object is the duplicates, which are things that we identify as meaning the exact same thing. For example, you could have a heart attack or a myocardial infarction, both on the problem list. They mean the exact same thing. So we'll flag those as duplicate and recommend that one of them becomes resolved so that the other can persist. Similarly, for related, what we'll do is we'll call out problems or diagnoses that are similar in nature, but these tend to be things that may have additional specificity that was not captured in a single term, such as type 2 diabetes mellitus may be one term, or type 2 diabetes with long-term current use of insulin may be an additional term that exists on the problem list, and we'll flag those as recommended for cleanup so that the provider can choose the more specific version of that to retain on the problem list. And this again has impacts to HCC, calculations and reimbursement to providers to ensure that the most recent and the most expressive version of the diagnosis or problem is on that problem list. So Sheena, coming back to you to talk about the HCC management.
Awesome, thanks, Blake. So let's talk a little bit more about how we streamline that HCC management, something I think that we've hinted towards throughout the course of this presentation, but we really believe that the problem list is the right tool to drive HCC management. And it is the clinical tool intended to manage those chronic problems longitudinally over time across encounters. HCCs are, by and large, chronic conditions that need to be managed over time. So why not use the tool that every EHR is required to have for its exact use case? So in addition to HCC identification and reconciliation, with IMO Core, we can do things like identify based on the patient's payer and plan type, for example, and an HCC list can pull together all of the confirmed HCCs for that patient, run them through the model's exclusion logic, and based on the last address date, flag the unaddressed HCC with our action color of orange. These flags carry forward to the problem list and allow the provider a view that is a well-maintained list that can quickly identify and reconcile those conditions.
Yep, so just to highlight one more piece, I think Sheena touched on it, but we do include those hierarchy and exclusion rules within our API, so that logic is built in for you folks, that you don't have to take care of all of those changing CMS hierarchy rules as they update year over year. So how to leverage this? The risk assess endpoint will, when calling it with a list of problems, will bucket things into two groups, whether it's addressed or unaddressed. And that will be done based on the HCC model version that is input into the request, as well as the last address date that is provided for the problem that is in the request. So for example, if you have asthma with COPD and it was last addressed in 2022 or 2023, we'll call that out as something as being unaddressed for this calendar year. However, if it has been addressed with the last addressed date in the 2024 calendar year, we will call that out as an addressed problem. So highly recommend to include those most recent encounter dates for all the problems so that this calculation can be performed correctly. And we also recommend to display all of the unaddressed problems along with that last address date within the actual UI itself, which you can see at the bottom of the screen. And you can perform these requests for both V24 and V28. How we've got it in this example on the bottom is that it's a two-sided view where you can go through the V24 model as well as the V28. Similarly, we could work to combine those into a combined view, which again, the IMO implementation team would be happy to work with your developers and your product team to understand how to go about doing this. But it's fairly straightforward, right? The risk assess response will provide back that information for whether something is unaddressed, addressed, along with those HCC category codes that you can, and those titles that you can properly display them to the end user in a logical manner.
Alrighty, so let's talk a little bit more about IMO problem discovery, which is a capability of IMO Core. So to help facilitate these well-maintained problem lists, the latest addition to our problem list capability, problem list discovery, can search the patient's record for HCCs that are not documented on the problem list, whether they were diagnosed on a previous encounter or mentioned in a clinical note, and present them within the provider's problem list workflow for consideration. So you'll see that to your right, the tab that is labeled suggested additions to the problem list does that sort of grouping and reconciliation right there for providers. But we also recognize that despite the promise of interoperability, many providers are siloed in their EHR and don't have the same level of visibility or awareness to the patient's HCCs that, say, a payer might have. So we're really excited about the problem list discovery tooling, not just for its ability to surface insights from within EHR data, but also as a platform for delivering payer-sponsored suspect conditions, as an example, or even care gaps, and identifying that to the provider at the point of care when they're primed for this type of decision making. So handing it over to Blake to talk a little bit more about implementing problem discovery.
Yep, thanks, Gina. So this is again a fairly straightforward request structure. So I didn't include it in the slide here. I mostly wanted to highlight the response so that you can understand how you could actually display that to the end users. But essentially, this discovery encounters endpoint will allow you to send in the existing problem list for that patient, along with any prior billing claims or outside data that you get that calls out when a particular diagnosis was captured in an outside system. And that can allow IMO to calculate and understand what are these problems that should exist on the problem list or that we recommend or suggest should be on the problem list that do not today. So the way to do this is, again, include all of the problems and all of the encounter records within the request. Based on that, we will auto-calculate these suggested problems for you. And that'll be returned in this discovery problems object of the response, along with the IMO title that can be displayed to the end user for acceptance or rejection into the patient record, along with any of the applicable flags or data elements that can be used to drive indicators within the response itself. So using this example of chronic diastolic congestive heart failure, let's say that it did not exist on the problem list today, we would identify that as a problem that we would recommend to add based on previous billing or encounter data. And that can be displayed in the UI in a number of different ways. Again, this can be done in a manner that fits your UI or UX and your own look and feel of the application. But how we've decided to display it in some of our own internal applications is through highlighting it in a green manner so that it is clear to the provider or the end user that, hey, this does not exist today on the problem list, but it likely should. And again, we can feed the exact same types of HCC category codes, category next indicators through this output to actually display that information to the end user effectively. But realistically, it's just the provider accepts it or rejects that suggested addition to the patient record. Okay, and Sheena, turning it back over to you to highlight some of the ROI on these components.
Sounds good. So we really believe in the problem list as the driving force for substantiated clinical documentation, clinical care continuity, and RAF score improvement and risk adjustment, and subsequently reimbursement as well. But there's quite a bit of evidence to back this up. So here's a study that's conducted by a site that implemented IMO Core and experienced a 6.9% increase in RAF post-implementation. This was attributed largely to a marked improvement in diagnosis specificity, upwards of 33%. And we'll dive a little bit more into the impacts of optimized coding and specificity at scale. But for now, I'll hand things over to Jordan for the next poll.
Thanks, Sheena. All right. So do you have HCC features and capabilities on your roadmap today? Is it something that's a short term in 2024 or 2025 and beyond, or is it just not on your roadmap at all? So please answer live. Give it a few more seconds and then I'll give it back to Sheena. All right, so mostly people are saying it's in their short-term roadmap for 2024.
And that's great to see. And I did see a question come in about how to leverage some of these capabilities, but we'll touch on that at the end here in the Q&A section. Okay, Sheena, I think who's next to you is.
Yep. So let's talk a little bit about those values of IMO Core and how those translate to value for both health systems and payers. We'll talk a little bit about the gap that currently exists between payers and providers. So essentially with IMO Core, we want to create stronger documentation at the point of care and meet the required standards to capture complete and accurate clinical patient data, again, at the point of care. So doing that upstream. We also want to enhance oversight and reimbursement opportunities by identifying HCCs from previous encounters. We talked a little bit about the discovery tooling, and we also want to reduce those disruptions in revenue and reimbursement cycles. So especially now in our industry, we're seeing a lot of these gaps start to close and a lot of conversations taking place around data transmission between health systems and payers. And so a lot of IMO's tooling and capabilities really help alleviate some of that gap and those common gaps that exist between EHR data and the financial, clinical, and operational challenges that really plague clinicians and health systems today. So poor documentation and incorrect coding initiates queries and directly impacts things like RAF score and value-based care and those subsequent reimbursements. And more importantly, they affect quality of care. So these are all measured in different ways, in a variety of ways within your organization based on initiatives and priorities. But IMO really helps to remove the guesswork by optimizing that data upstream. The accuracy, specificity, and clinical documentation really do matter, and that starts with the clinician at the point of care. A really great example of this is work that we currently do with payers and providers. So what we'll see on the next slide is an example of what an IMO payer integration could potentially look like, right? And so you'll see here in this overview, the IMO health plan provides IMO with member information and gap data. If a patient is matched, the gap data is presented to the provider in workflow, and then the health plan provides supporting evidence that's made available for review. Again, that's in real time. Those engagement metrics are then logged for reporting back to the health plan. So think of this as a bidirectional ecosystem. Again, something quite revolutionary in the space. This also gives us the opportunity for potential data retrieval and can also support care gap identification. So on the next slide, we'll kind of talk a little bit about what this means overall. So regardless of your health system type or size, whether that's a payer model or a payvider model, IMO really provides you the opportunity to clear that path to accurate clinical patient data. The value is evident. We offer fully integrated bidirectional communication with providers at the point of care. You get that clinical terminology that is our expertise that's leveraged by providers in your HIM platform. And we standardize and enrich that clinical data in workflow in real time. So I am going to turn it over to Jordan for what I believe is our final polling question.
Yeah, thank you, Sheena. All right, so this is a short answer, but what factors are most important for determining ROI of net new capabilities around HCCs? I'm going to give you guys a few seconds to fill it out, and then I'll get back to you. All right, we're going to go ahead and close out.
Okay, thanks, Jordan. So one quick plug before we wrap up here and get into our QA session. I did want to highlight that anyone with an IMO Core license today does by default get access to our IMO Studio platform, which includes the ability to download what we call reference data sets. So I'm highlighting on the screen here the opportunity for folks to download any of the code systems that we manage. So these reference data sets are essentially just pass-through files from the source systems themselves. They're massaged slightly by the IMO team to present these in a more usable format for your purposes. And you have the opportunity to download things like the ICD-10 library and catalog, as well as the CMS HCC model data. There are other code systems that are included in this as well, like ICD-10 PCS and one codes. So if you don't have access to Studio today, we'll follow up with some information around how to get access to that if you're a core licensed user already. Okay, so the key takeaways from today, and we hope that you all got out of this conversation, is that the gaps in the provider to payer ecosystem can contribute to a variety of challenges in our industry, which all have impacts to the care continuum. Terminology and technology both have the potential to help optimize these relationships between not only the providers, but the payers as well. and the improved ability to capture HCCs and manage those chronic conditions and those comorbidities, especially ensures risk stratification, which can help reduce cost, as well as the burden to care across our industry and improve outcomes. So those pieces that Sheena was highlighting earlier around the criticality of documenting with specificity at the point of care are extremely important. As well as organizations are committed to reducing gaps in care, relying on technology for consistent, reliable tools that optimize data and provide proactive solutions to simplify workflows. So essentially everything that we covered today, you folks should be able to leverage to help improve your ability to manage these gaps in care. Again, IMO Core also enables that reference data set access via IMO Studio. And finally, I'll highlight that for those of you that have a core license and have not implemented some of these capabilities, our IMO implementation team can help with some at-the-hip support of these to adopt these features. So if you have not implemented some of these features already and are looking to, you can reach out to our customer support team. It's customersupport@imohealth.com. I can also put that in the chat here in a second. That will put you in contact with our implementation team, and we provide guidance in a highly consultative fashion, where we'll go through presentations much like this, where we'll highlight how to solve the certain problems that you're looking to solve and how to use the IMO terminology, services, and solutions to help meet those challenges that you're trying to work through. Okay, and yeah, one more thing before we get into Q&A. I did want to pull up just a very quick little demo that can demonstrate how easy it is to get your hands on these APIs and leverage them. Obviously, the integration into your actual application to leverage within your UI UX will take a little bit more effort, but the API implementation itself is extremely straightforward. Should not take too much time to stand up. Typically, for these problem list management tools, the UI UX is really the larger lift on the partner side. So what I've got here is just a very basic UI wrapper or UI wrapper around our API, just to highlight the information that can be sent along to these request endpoints. Now I'm going to hit this button one time, but it's going to make 4 different API calls in the background, leveraging all the different endpoints that we talked about today. So to categorize, to clean the HCC organization and the discovery endpoints. Now what you see here in these data elements are, on the left-hand side, the existing problem list, along with the problem, the onset date of that problem, and the last time that problem was addressed. And then on the right-hand side is to help enable our discovery functionality, which is the input of any sort of diagnosis from claims data, billing data, outside data that you might have gotten for things that don't exist on the problem list today. Similar format of the problem as well as the onset date of that condition. So if I hit process, again, this is going to make 4 different API calls in the background, and I'll walk you through what this looks like here in the output. So on the left is sort of generally just how problem lists are typically sorted, whether it's based on the entry date or an alpha sort on these things, highlighting that against the categorized view of these problems to help highlight how easy it is for a provider to look at a given clinical area or condition area and pick out the relevant information that they need so that they can move along with their day faster to help provide the right level of care at the right level of detail to these patients. So what we'll do is we'll take all of these problems and bucket them into those clinical categories. Here, this little red up arrow is my very rudimentary way of showing an HCC indicator. So based on what I was calling out earlier in the presentation, you can leverage that data to highlight things like an HCC indicator within this categorized view. Additionally, we'll, for the clean endpoint, we'll highlight those lapse, duplicate, and related problems based on what has been input. So again, those lapse problems feed off of that onset date of that problem. Duplicate problems are things that we identify as conceptual duplicates. ALS and Lou Gehrig's mean the exact same thing. And related problems are those that are tend to be within the same condition space, but may have additional specificity over the other. For example, diabetes versus type 2 diabetes. Same goes for the HCC organization, bucketing these under the unaddressed or addressed categories. We can see that a lot of these problems have not been addressed within the last calendar year, but just to show you the effectiveness of this endpoint, if we wanted to say something like ALS was last addressed in 2024 and reprocess this data, we'll now see that that ALS hierarchy bucket gets dropped into that addressed bucket. So based on those dates and the cancellation logic that we have built into the API itself, this will organize those things efficiently for you and the providers to display something to them to make those determinations of whether that condition should be looked at for that visit in that calendar year, et cetera. Finally, for our suggested problems, based on what is existing within the problem list and what we found within the diagnosis data that's sent from, again, claims billing or outside sources, you're able to suggest different problems to the provider to add to the problem list for conditions that we identify as lacking. Now, what we've done here is group these under the different HCC model category buckets, so that, for example, for the diabetes with chronic complication bucket, you may have a type 2 with stage 4 CKD, as well as a type 2 with stage 5 CKD. Likely makes sense for the provider to just grab one out of that bucket, especially since the stage 5 is the further progression of that disease. So again, this is just a really light UI wrapper around the API. I'm just going to show you some of the raw responses that you get. For example, when you pass in the problem to the categorize endpoint, you get that category name along with the IMO description that's sent along and those HCC category values. And again, going back to earlier in my presentation, just very straightforward to highlight those indicators and to put things into that structure based on the response from the API. So continuing to go down, as you'll see, right, the next bucket from before was cardiac and vasculature, and that's going to contain our hypertension term and any others that would be identified there. Okay, and then for the HCC organized response, highlighting this again, you've got your unaddressed bucket, which contains those different HCC categories and the titles, along with what those diagnoses are or problems are that have not been addressed within this calendar year. And if we go down to the bottom, you'll see this addressed bucket, which includes anything that has been addressed. And another piece of information here is based on that last address date that was included in the request, will demonstrate that it has been addressed within that calendar year. Okay, so hopefully that was a helpful quick little demo to highlight the ease of the implementation through the API responses, and then we can jump into our Q&A session.
All right, thank you all. All right, so this time we'll be kicking off our live Q&A. So if you had any questions from the webinar today or anything like that, please enter them now, and our team will begin answering. As we start receiving your questions, just please excuse any brief silence while our team reviews and answers. So we do have a few questions coming in. And June, this one's for you. So many provider organizations still rely on fee-for-service for their practices. From your experience, may you comment on how your provider clients have successfully shifted and or are shifting to value-based care practices?
Yeah, that is a great question. And with these different models, first, I would like to say, as far as from what I have seen with our customers, the definition of success is unique to their organizations, typically very specific key performance indicators or KPIs that organizations have. But in general, from what we have seen, the for this shift in moving from a fee for service towards a value-based is really around a lot of the things that we have talked about during this webinar, and having information in front of the provider. Since the risk adjustment model and CMS's HCC is over time, and its perspective and the conditions need to be addressed yearly, so that having tools of help in front of providers to help them manage this as they are shifting to this model and fitting the and balancing it with the fee for service, because yes, there are individual encounters that are still occurring, the documentation for that. However, in the value-based models is the providers now are accounting and looking longitudinally. And so having this information available to, as Blake talked about, when was a condition last addressed? And as Sheena talked about, having your problem list clean and organized so you can see those factors for providers just supports them in their decision making to manage that long-term care of the patient and their gap. And I will see if others, Sheena or Blake, have some additional thoughts to that.
Yeah, June, you took the words right out of my mouth. It's really a mindset shift, and all of that really is different from organization to organization. But what we've seen is organizations that have made a commitment internally to shifting providers' mindsets from that sort of volume-based perspective to a shift towards focusing on health outcomes is really the first step. The second step is ensuring that providers have a full picture of patient care if we're expecting them to manage patients' care longitudinally. So I think that the IMO Core suite of capabilities and our terminology really set providers up for success in that regards, and organizations as well.
Nice. Another question came in. Blake, I think you're best suitable to answer this, but how do you know, or how do we know which HCC to service and how to blend both models?
Yeah, so I think it's pertinent to providers to understand both the V24 and V28 HCC models, especially if there's a patient population on your end that would warrant displaying that information. But as June mentioned, as we're moving to more value-based care, I think HCCs are extremely important. So we would recommend displaying that blended model of V24 and V28 and not picking and choosing between hybrid. And if we refer back to one of my earlier slides, we can take a look at what the technical how-to is on how to present those to the end user, but I'm also happy to engage individually with anyone who needs to get additional clarification following this presentation.
Got it. And then once version 24 goes away, how is IMO going to support a blended HCC model?
Yeah, so right now, we don't know what CMS is going to do in the future in terms of models, if they're going to move to a single model in the future, such as they're just going to transition over to V28 as V24 is phased out, or if they're going to make, let's say, a new V29, V30 model. We just don't know because we don't have insight into that at this time. However, we've set up the API responses in a way that we feel we would continue to be able to not only support a single model if it goes to that route, but also a blended model if CMS decides to do that in the future as well. So the HCC model cat attributes or category code attributes will contain sort of the previous version of HCC or that lower version, whereas the _next or anything with next in the name will surface the most recent version of those HCC codes. So for example, if we switch to like a V28 and V30, that V28 information will move from the next field into the regular HCC field, and the V30 will go into the new HCC next field. So we'll basically do a shuffle of the data to help support any sort of future model changes. Now, again, we don't know what that exactly is going to look like Once we do, we will be sure to reach out to all of our partners and ensure that it's clear that any sort of data model changes that we're making can be accounted for on your side.
Great. So does IMO have any best practices on how we display or calculate RAF scores?
Yeah, so for actually calculating RAF scores, that gets a little bit more in the weeds. CMS actually has some free model software calculation out there, or model calculation software out there that we can provide in chat in a second here. But by and large, IMO does not consume some of the data that is required to actually identify what that true RAF score should be, because there are patient demographic information that is required for us to actually determine, or for you to determine, what the true community factor should be. IMO does not receive that data today, since it is PHI, and nor will we in the future, at least at this point. So what IMO does is we provide all of the data necessary to return or to get that information from the model. And then based on that patient demographic information, you can choose the correct RAF score to then actually calculate the true RAF impact downstream.
Hey, I believe there's a couple questions that follow along that line around the disease interaction and demographic-based factors. Is those resources are available via the links that Blake will put in the chat, because of the complexity around that information that is needed as well.
Okay, so it looks like we have reached our end of our Q&A. So I am going to go ahead and close out for today. Thank you, Blake, Sheena, and June so much for doing this webinar. And also thank you to everyone who attended today. Really appreciate it. And I hope you have a great rest of your day. A reminder that the recording will go out later this week, in addition to other resources that mentioned earlier. So thank you again.
Thank you, everybody.
Bye.
Bye.
Thank you.